Hello, everyone. Uh, People are joining now, and we can see on our screen. So we will wait for a few more seconds or minutes, and we'll start the webinar. Okay. So hello, everyone. Good morning, good afternoon, good evening. My name is Mena Sharma, and on behalf of the George Institute for Global Health, I warmly welcome you all to the sixth Evidence to Policy virtual lecture. Each year, we host this lecture to spark conversations around bridging the gaps in public health policy implementation, and it is delivered by a leading global researcher every year. Past lecturers have included Professor Srinath Reddy, Professor Ian Jacobs, Dr. Rajni Ved, and Dr. Ophira Ginsberg. This year, we are delighted to have Dr. Justin Koonin, who will share his contrasting experiences as a local community member and as a steering committee member of global policy bodies, including his role as co-chair of UHC 2030, which is the International Multi-Stakeholder Partnership for Universal Health Coverage. His lecture will shed light on the intrinsic value of community engagement and outline different aspects in design and implementation of public health programs. Following the lecture, there will be a fireside chat moderated by Ms. Rosemary Mubru, Executive Director, Wasi Health Kenya, which will bring in more interesting insights for all of us. Thank you all again for joining with us today. We encourage you to actively participate and put in any questions or comments in the Q&A box. For those who are tweeting, please use hashtag E2P2023 in your tweets. I will now hand over to Professor Vivekanand Jha, the Executive Director of the George Institute for Global Health, India, for formal introductions of the speakers. Over to you, Vivek.
Thank you very much, Mana, and greetings, everyone, and welcome to all of you for joining this annual Evidence to Policy lecture, which is one of the highlights of the various things that we do here at the George Institute, India. So just to add some more context to what Mana just described, why are we here today, and why have we chosen Dr. Justin Koonin to talk about the topic that he is going to address in detail? We have realized over the last few years that engaging communities in designing and promoting health and well-being is really the logical thing to do. And not only logical, but it is also necessary to any success if we want that as a goal. But we really are not great at identifying how is it done effectively, both at a local and at a global level. Can we use the insights that are provided at local level to shape policies at a global level, which are relevant and can be implemented in a variety of contexts? So it is here that we will want to learn from the expertise of Dr. Justin Koonin, who is the co-chair of the steering committee of UHC 2030, which is the International Multi-Stakeholder Partnership for Universal Health Coverage. He is also a member of multiple WHO expert panels. He, as you can see from the slide that you have in front of us, is an adjunct associate professor at the Kirby Institute in the University of New South Wales. And we are privileged that he is a distinguished fellow and an honorary professorial fellow for the George Institute for Global Health. At a national level, Justin is also the president of the AIDS Council of New South Wales, which is Australia's largest community organization that is dedicated to the care of HIV/AIDS patients, their prevention and support to the community, as well as to the health of sexuality and gender diverse population more broadly. He is a distinguished fellow, as I said, at the George Institute. And he is also a fellow of the Australian Institute of Company Directors. Interestingly, Justin's training is in the field of pure mathematics, and he also serves as an investment analyst. So really a multifaceted personality, and we're privileged to have you with us, Justin, and we are looking forward to listening to your perspectives on designing and promoting health and well-being with community engagement. Can I have the next slide, please, Justin? As Mana said, following the lecture by Justin, we will have a follow-up conversation, which will be moderated by Rosemary Maburu, who has been a champion for healthy communities for over 15 years, and currently she serves as the executive director of Vasi Health. She is a civil society leader in Africa and has extensively worked on supporting civil society to engage the decision makers in the community at all levels, be it local levels, national levels, and also at global levels. She is a civil society organizer who is working on building and strengthening civil society networks and platforms for health-related advocacy and campaigning in Africa. She has a master's in public health from Ohio University and has combined with the master's in business administration from Frostburg State University of Maryland and a Bachelor of Education from Kenyatta University in Kenya. She as a civil society organizer who has worked on building and strengthening civil society networks and platforms for health-related advocacy and campaigning in Africa, will bring her perspective and perhaps raise and use the questions that we will get from all of you who are here with us on this virtual platform to build a very, very useful and fruitful conversation, which I hope will be rich in content and will try to clarify many of the issues that we find difficult to understand and navigate through so far as civil society engagement in our work is concerned. So with that background, it's my privilege to request Dr. Justin Koonin to take over and deliver his lecture, after which we'll seamlessly pass into the fireside chat. Over to you, Justin.
Thank you very much, Vivek, for that warm welcome. It's a privilege for me to join the George Institute family and to colleagues here in Australia and afar. It's really good to see your faces. It's customary in Australia to begin by acknowledging the traditional owners of the land on which, well, in this case, I'm speaking, and they are the Gadigal people of the Eora Nation. So I pay respect to their elders, past and present. The painting behind me is from the Central Desert region of Australia and tells the story of the Seven Sisters, the Pleiades constellation, and is a reminder of how old our culture is here in Australia, and as it is, of course, in India. So Vivek, as introduced, my background really is in community activism. And it's that perspective that I want to bring. And with various hats that I wear, I'd like to talk today a bit about what the global perspective on UHC looks like. UHC, of course, universal health coverage. And then turn it around and talk what the local perspective looks like. And then finally, how do we actually bring these two worlds together? So as a very loose structure to my presentation today, that will be it. Please put questions in the chat. I look forward to an engaging conversation in a minute. And I'm very grateful to share the screen with my sister Rosemary from Kenya. We've worked together closely for a number of years. So let's talk firstly about the global perspective. And I suspect many of you will know this background, but let's just make sure that everyone is on the same page. So the UN has Sustainable Development Goals. They were initiated in 2015, post the Millennium Development Goal era, which started naturally at the turn of the millennium. There are 17 Sustainable Development Goals. They're all interconnected, but the main health goal is goal 3, good health and well-being for all. Within SDG 3, and there was a lot of negotiation around the time of the SDGs coming into force. Goal 3.8 is around universal health coverage. And in some sense, I mean, this may be a biased view, but it's sort of the umbrella goal for the health goals. And universal health coverage includes both access to essential or quality essential healthcare services, as well as medicines and vaccines. And importantly, it also includes this dimension of financial risk. So a lot of people in the 21st century have had increasing access to health services, but they've also been pushed into financial and sometimes catastrophic health expenditure to achieve those. That's not what we want. Overarching all of the Sustainable Development Goals is this idea of leaving no one behind. In other words, putting the most marginalized and most vulnerable first. And so it's the equity dimension. So a working definition of UHC that I will be using and is commonly used by WHO and others, and again, many and perhaps most of you will be familiar with this, is that UHC means that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So that's a bit of a mouthful. Let's dissect it a little bit. And often we talk about the UHC cube, and you can see that in the bottom half of the diagram below. So we're talking about who gets covered. That's really the equity dimension, which, you know, every country would like to cover as much of its population as it can. Sometimes there are issues which are not just technical but political around key and vulnerable and marginalized populations, and we can talk about some of those later. But there's this dimension of who gets covered by health programs. Along another axis, there's the question of what gets covered, because of course no country has the resources to provide all health services, and so there are sometimes technical questions about what gets prioritized. But importantly, this dimension also highlights that spectrum that I noted in the definition above, so that we're talking about promotive, preventive, curative, rehabilitative, and palliative services, the whole life spectrum. And so we're not just talking about, for example, what happens in a hospital. And then the third dimension is, how do these services get covered? In other words, who pays for it? And that's a very important dimension. Sometimes UHC gets reduced to a discussion of national health insurance schemes. And national health insurance schemes are incredibly important, but it's important also to remember that they're only one dimension that leaves out these questions of the full spectrum of care, so what gets covered, and also the equity dimension, which is often a human rights dimension of who gets covered. So that's what we're talking about when we talk about UHC. Probably many of you know all of this already. Here's a sort of potted history of the UHC movement, and I guess we can trace its roots all the way back to the 1978 Alma-Ata Declaration, which was the first time that primary healthcare was mentioned to the extent, at least, that it was in a political declaration. When we talk about UHC, you can see it in the bottom right of this slide. We think about UHC as the goal, health system strengthening as the implementation means, the way we get there, and the particular approach that has proven time and again to be the most efficient and effective, what we call the value proposition, is primary healthcare. In other words, prioritizing community health, multi-sectoral, integrated, people-centered health service, so close to people and communities. And so that is why we talk about UHC having its origins in primary healthcare and the Alma-Ata Declaration. And what followed was, I'm definitely not going to go through everything on this slide, but a sort of building movement which recognized that it was not sufficient just to tackle one disease at a time, HIV and malaria and tuberculosis and NCDs and so on. But rather that we need to tackle the underlying causes which make health systems vulnerable and which prevent us from tackling these diseases. And to be sure, there were tremendous gains on many of these diseases, particularly during the Millennium Development Goal era, and those were incredibly important. But there was a yearning also for something broader. When Dr. Tedros came in as, well, I should backtrack a bit to say that, of course, in 2015, UHC was recognized within the Sustainable Development Goals. And then from a WHO perspective, when the new Director General came in 2017, Dr. Tedros, he saw UHC as a top priority. In green, you will see items particularly related to the UHC 2030 partnership, and that's sort of my key involvement with the UHC movement. And I'll speak about that in just 1 second. To highlight at the end of this graph a couple of key moments. In 2019, we held the first ever what's called a UN high-level meeting on universal health coverage, which is when the heads of state get together in New York, many heads of state at least, and together come up with, well, negotiate, but then come up with a so-called political declaration, which is meant to guide the world's efforts in this domain for the next several years. It was in 2019 a fairly landmark moment. It was certainly the broadest declaration on human health in our history. And then right after that, COVID-19 happened and caused us to revisit many of our assumptions and perhaps our hopes for progress. You'll note that 2023, this year, will see the second ever high-level meeting on universal health coverage, and that's a particularly significant moment. So how do we actually get there? It's a big goal, and I will come to communities in a second. But the overall global framework, and I really love this framing that comes actually from Thailand, which is a real champion for UHC, and interesting, not a country with huge material wealth, at least at the time when its UHC programs were put into place around 2000, GDP was around US $2,000 a year, but nonetheless very effective. And they talk about what they call the triangle that moves the mountain. So for the movement as a whole, 3 things are needed. You need higher level political support. So there's the political wing, the government. You need technical capacity. You need knowledge. So this is the researchers, people like the George, but also WHO and many other multilateral partners. And then importantly for today, you need a social movement. You need the people, civil society, communities, and probably also private sector, media, others are included in that bucket as well. And so these 3 sectors, or these 3 segments, really all need to be functioning, and as we'll come to later, need to be working together to make progress on these big societal movements like UHC. So a little bit on UHC 2030, which, as Vivek mentioned, is sort of the multi-stakeholder partnership that was set up to accelerate progress toward UHC. It came out of something called the International Health Partnership, which was more focused on effective aid cooperation. But when UHC came into the Sustainable Development Goals in 2015, UHC 2030 was born. It has a formal role in these UN high-level processes, and I've included a paragraph at the bottom there in what's known as the modalities resolution for, in this case, the 2023 high-level meeting. This is put out by the UN General Assembly sometime about 18 months in advance, sometimes a bit longer, of the actual meeting itself. And so UHC 2030 is sort of named as the partnership which coordinates input towards the high-level meeting, and for that reason, which I'll come to later, has a semi-official, well, actually an official role in how this global process works. We're hosted by WHO, the World Bank, and the OECD, but the way the partnership operates really seeks to give life to this vision of the triangle that moves the mountain, in that it's a multi-stakeholder partnership. Our steering committee is comprised of member states, there's government, of multilaterals, World Bank, WHO, UNICEF, the Global Fund, Gavi, and so on. There's philanthropic foundations, there's the private sector, and importantly, there's civil society representatives. And I'm happy to say that Rosemary and I have both served in that capacity at some point. There's also the political wing, and our political advisory panel is led by Her Excellency Maria Fernanda Espinosa, who was president of the 73rd UN General Assembly. And stay tuned, because we may have organized for a special guest to come and talk with colleagues at the George Institute and others in coming weeks. And then there's a much broader partnership. At the moment, last time I counted 159 formal partners to to the UHC 2030 Global Compact. About half of those are governments, but also international organizations, civil society, private sector, academia, and media, and so on. And so the idea really is to try and bring the sectors together in a way that doesn't always happen. To the civil society aspect, the civil society constituency led by those civil society steering committee representatives is called, well, somewhat unimaginatively, I was partially responsible for the name, but the Civil Society Engagement Mechanism for UHC 2030. And it acts really as a standalone constituency, part of the broader movement, but able to amplify the voices of civil society on a global level. You can see some of the activities there. I won't go through them in detail, except to say that from a standing start in 2016, it's developed into a sort of a much broader network. So you have steering committee representatives, alternates. This model has been followed in numerous other multilaterals, the Global Fund, UNAIDS, and so on. An advisory group numbering 18 in total. And then actually these numbers are slightly out of date now, but it's more than 1,000 individuals. We're up to close to 1,000 organizations in over 100 countries. So I say this both to give some examples of my personal involvement, but also to highlight the ways in which civil society is beginning to be able to have a louder voice in international fora. Now, I mentioned that there is a high-level meeting coming up in 2023. And again, I want to continue by sort of framing this global conversation about UHC by giving you a little bit of an idea around what's happening in the next few months. Some of you have been engaged already in these discussions so far, some of you not yet, but please stay tuned. So the first thing that happens in these global discussions that happened in 2019 and again this year is the development of what we're calling the action agenda for the UHC 2030, for the UHC high-level meeting in 2023. In 2019, we formed something called the Key Asks for the UHC movement. I'll come to what they are in a minute. But this was a broad multi-stakeholder consultation, including to a significant extent with civil society. We've done it again, obviously in light of what's happened in the 4 years since the last high-level meeting, a much greater emphasis on aspects of health security and emergency preparedness have come out. And that's a really interesting development. So there's this sort of first formal consultation. That period has happened, and I know people from the George were involved, perhaps some of you, and that's terrific. What happens then is it'll be actually May the 8th and the 9th, the UN General Assembly holds what they call a multi-stakeholder hearing. And this is an opportunity for principally civil society, other stakeholders as well, but to speak live at the UN General Assembly and to have those voices heard. And then together with the outcomes of the agenda consultation, plus the multi-stakeholder hearing, plus technical inputs from WHO, UHC 2030 and others, what's developed is something called a zero draft. And the zero draft is kind of the first version of what later becomes the political declaration on universal health coverage. Of course, between the zero draft and the final declaration at the high-level meeting in September is a lot of member state negotiation. And sometimes what comes out at the end, there's, I won't say no resemblance, but not so much resemblance to what went in because of the politics of member state negotiation. But nonetheless, there's a fairly direct pathway through which civil society can have a voice that gets reflected to some extent, of course, with other stakeholders in the zero draft, through the multi-stakeholder hearings. Hopefully there'll be some familiar faces. Maybe some of the people here will be at those multi-stakeholder hearings. And so this is one way that civil society gets to have a voice at the global level. I mentioned that I would talk a little bit about what the action areas for the high-level meeting. So this is the action agenda. The launch is in late March. Please stay tuned for that. We'd love to see you there. So I won't give away all the details, but they're around number one, political leadership. Remember the triangle that moves the mountain. They're around leaving no one behind. So this is the equity dimension at the center of the Sustainable Development Goals. They're around enabling laws and regulations around the healthcare workforce, around investment, so financing for health. They're around what we're calling moving together, so multi-stakeholder, whole of society approaches to UHC. Gender equality has been increasingly seen as one of the biggest barriers to realization of these goals, and the outcomes for women and girls are vastly more difficult than for other genders. And so it was certainly felt across a broad consultations that it was important to make demands on gender equality. And then finally, this interesting, and it's the subject of another lecture, I won't go into it today, but the connections between UHC and health security, and perhaps in a couple of sentences, really they're two sides of the same goal, and the principal means by which you achieve universal health coverage and health security or emergency preparedness is through strengthening health systems with a primary healthcare approach. So they're very closely linked, but don't always talk together. So this is the action agenda that UHC movement is taking forwards, obviously including areas like leaving no one behind, including areas around moving together and multi-stakeholder input. There's a clear emphasis on the need to engage civil society and communities. And then at the end of this whole process, post-member state negotiation in, well, it'll happen sort of May, June, July, but the meetings in September, you get this thing called a political declaration. Many of you will have seen them in some form before. I've included in slides around the political declaration of the high-level meeting from 2019. You'll see it's a very formal document. This is the first page of many. And it's, you know, it's meant to have global impact. And in theory, what happens is that member states agree to a declaration like this and then go home and implement them in their own countries and according to their own context. In practice, it's not always so simple, not least because these, while member states are accountable in the sense that they will come back and have to report on their progress, there's no legally binding mechanism in which the commitments made here are held. And so the real question that all of us involved in this, and I've given a broad sort of global context of what's going on, ask is fine, but how do these decisions made in New York and Geneva reach local communities in Soweto and Sao Paulo and Mumbai? And if they don't do that, then actually what's the point of doing them in the first place? So that's the global suite of what's going on. Of course, much to discuss. I want to pause now and take a very different approach, which is a local perspective on UHC. And again, from my own local experience here in Australia. And very much issues around access to health services are human rights issues, are issues of discrimination, are issues of vulnerable and marginalized populations. And that's something that we've seen certainly in Australia, in New South Wales, my state, but also across the world. And so that's how I became interested in this movement, really. So backing off quite a lot, I'm going to talk about my local context. As again, Vivek mentioned in the introduction, I'm president of ACON. ACON used to be known as the AIDS Council of New South Wales, as it was founded in 1985 at the height of the AIDS epidemic here. I like to say that just as I do have Kentucky Fried Chicken in India, Kentucky Fried Chicken, American fast food chain, Kentucky Fried Chicken became KFC because it wasn't all just about fried chicken. ACON, the AIDS Council of New South Wales became ACON because our agenda at some point, indeed around the year 2000, expanded to incorporate not just HIV, but the health more broadly of the key and principal populations. I don't know why it's doing that. 1 second. There we go. ACON had expanded its agenda to incorporate the health more broadly of key populations affected by HIV, and principally in Australia, that is sexuality and gender diverse people. In other words, lesbian, gay, bisexual, transgender, queer people. There are other communities affected, certainly injecting drug users, sex workers, but ACON principally focuses on those sexuality and gender diverse communities, but in a much broader lens, including mental health, including alcohol and other drugs, domestic violence, workplace inclusion on the sporting field, and so on. So it's an organization that operates at a local and sometimes national level with a very particular subpopulation, which has been marginalized, of course, in this country, but also no doubt in India and also in many other parts of the world. And so it's a very different lens from the global lens, where we're really moving forward a whole overarching movement. Let me see why, there we go. We're actually Australia's largest HIV and sexuality and gender diverse community organization, and funding, interestingly, this doesn't happen everywhere, but we're largely about 2/3 funded by government who support us. Also through, we have membership fee programs around workplace inclusion and fundraising, but from the beginning, the government has been a key stakeholder. And from the beginning, this is now 40 years ago, and I think this is a key point. The work has really been founded on partnership. We in fact call it the partnership, and it's a partnership of governments, of politicians, of policymakers, of researchers, of clinicians. I'm very pleased to see Professor Andrew Grulich, who's been central to this from the Kirby Institute here today, and critically of affected communities. And I think that's been the hallmark of a successful Australian response to HIV. The involvement of communities from the start of the epidemic. Government funded us from the beginning to run programs our own way in the language our communities would understand, and that often has been quite explicit, and language that might not be used in the mainstream has been critical to the success. I put this up as a demonstration, and acknowledge that there are a few gaps between the last slide and getting to this conclusion, but actually HIV is on an incredibly exciting trajectory in New South Wales, the state where ACON works. You'll see there a slide of HIV or newly diagnosed HIV infections from 2008 to the present. And we're on a path where we can look at effective elimination, certainly by 2030 and hopefully before then. And there are many reasons for this, including the advent of, well, antiretrovirals previously, but pre-exposure prophylaxis, many other biomedical advances. But critically, I think, and the government and the researchers would acknowledge, the role of community in working with our own communities has been critical. So my country didn't do everything right, for sure, on many issues, but on this one and the partnership that established in really the early 1980s, it's been quite a success. As a snapshot of why it's important, I mean, maybe all of us on this call know this, and I'm preaching to the converted. I want to give you an example, a very recent example of what happens when governments communicate to populations versus what happens when communities communicate to population. And this comes actually not from the HIV context, but on another health issue relating to the same communities, monkeypox or mpox, which of course has been a recent challenge. Sydney recently hosted World Pride, the largest LGBT festival in the world. And so we had an influx of international visitors. And in the lead up, New South Wales Health, so our government department, put out a post encouraging people to get vaccinated. And I want to say at the outset that New South Wales Health is a good and consultative department, and they did nothing wrong. But this was a social media post. And if you look at the comments, there's a lot of anxiety there. This is really poorly worded. People aren't going to be at risk of acquiring mpox just by attending festivities. How do you know it's safe? And most of the comments on this social media post looked like this. What happens when ACON put up a similar post? So this is our post of a few months previously. Please go get your monkeypox, your mpox vaccines. And the comments were, ACON's always coming through for the community. This is really important. When can I get mine? That's great news. I really want to be vaccinated. And I think what it demonstrates is that one of the critical enablers of successful health-seeking behavior is trust. And communities have to be involved because, or community organizations have to be involved because the community is trusted. And again, I want to stress this is absolutely not a criticism of the health department. In fact, I think they would agree that community organizations and community controlled and based organizations in particular can access their communities in ways that the government cannot. So it's reasonably obvious to those of us that have been involved on the ground that this has to be a central feature of any effective global response to health system strengthening and to the challenges that come on and will come in the future. So then the question is, well, okay, how do we bring these two worlds together? You have this large global apparatus making political declarations, decisions made by people who don't necessarily have deep connections to community, who aren't used to working with community in many countries, operating where there isn't civic space for community to flourish and to hold governments accountable. How do you connect that with the reality that you absolutely need communities on the ground to be doing this work, or you won't get the work done? And my answer to that, and in the 15 minutes that I have, I won't be able to answer it sufficiently, but let's start, is that you do it from the top down and you do it from the bottom up. You take every angle you've got. So I want to talk now about social participation. And I guess by social participation, I mean the inclusion and involvement of civil society and communities, not just in service delivery, as we've seen in the examples previously, but also further upstream in health planning at the national and subnational levels. Why is it important? Well, I think that the COVID-19 panic, I mean, we knew this before, but COVID-19 has exposed it even more, how crucial trust was between populations and the health system. And that trust can't be built overnight. It needs to be built over time so that when there is a crisis, the relationships already exist. We saw that during COVID-19. There are some countries in the world which have had already established mechanisms for the kind of consultation that I'm talking about. Thailand is a really good example, but France, probably Kenya too. Rosemary, you can talk about that. Tunisia, actually, interestingly, had national dialogues. Many countries don't do this well. And what it speaks to is the need to institutionalize these capacities for social participation and for the integration of civil society and communities in national, subnational programs. And so that's what I'm talking about when I speak about social participation. And very briefly, for the reasons I've discussed previously, this is why it's important. So with this in mind, WHO, it's Health Systems Governance Cluster, and some of you may have seen this, but I'd highly recommend it if you haven't already had a look at the resource. From about 2019 to 2021, developed what we call the Handbook on Social Participation for Universal Health Coverage. The link is there. I'm happy to share these slides later. I know you probably can't take them all down now. And the idea was to provide member states guidance in terms of, okay, how do you actually incorporate civil society communities into these processes? How do you deal with issues of representation? How do you know the right people are at the table? How do you ensure that the quietest voices get heard? So the handbook is an extremely useful resource, but it's just a start around what we do at the global front. And I want to highlight another global process. So you can see at the start of this timeline, the launch of the handbook in 2021, and indeed multiple dialogues around these topics with the WHO Director General, which moved the agenda forward. What we're actually trying to do now is, so I mentioned the processes that happen at the UN General Assembly in New York. Of course, the health version of that is the World Health Assembly, which takes place in May in Geneva at WHO. Led by, unsurprisingly, Thailand and other supportive member states. There are plans afoot for a resolution dedicated specifically to social participation. In other words, a political commitment to social participation at the World Health Assembly in 2024. So obviously, like the high-level meetings on UHC in New York, there's a lot of prep time. There's been a number of consultations. There has been surveys prepared by the health system governance team. There will be, if anyone is in Geneva in May for the World Health Assembly this year, a side event co-hosted by Thailand, Norway, many other countries behind it, but also UHC 2030 and CSEM. I obviously don't have time to get into the nitty-gritty, except to highlight that there is this plan further afoot for explicit recognition of the importance of social participation in international fora through a World Health Assembly resolution. The other thing, and perhaps this is where I will come to a close around these sort of introductory remarks, extended introductory remarks before we have a conversation, is to highlight something that's really, really significant that's happening, in fact, at the George Institute. I said you want to tackle these issues from the top down and also from the bottom up. And what we noticed is that in a way, there's really a gap at the community level, in that many community organizations want to engage in these broader UHC and health system discussions and also implementation of what it takes to get there, but are simply not resourced to do so. If you're like my community organization and no doubt many others across the world, you're running pretty flat out to deliver the services that your community needs. And so the space to actually deliberate on these topics of social participation is limited. So the George Institute has teamed up with a number of partners, UHC 2030 and its civil society engagement mechanism, Management Sciences for Health, who host the Secretariat for the Civil Society Engagement Mechanism, and some country partners, and I will mention them in a second, to develop something called SPHERE, Social Participation for Health, Engagement, Research and Empowerment. And it's really a research project around what it takes to effectively, or to generate effective social participation at the community level in national and broader processes. You can see the website there. No doubt some of you have heard of it before. I'm super pleased that the Secretariat for SPHERE is hosted in the George Institute in India. I did see colleagues involved online a little bit earlier. Devaki, who is not here today, is leading this work. The idea behind the project is, first of all, to document experiences of countries in promoting social participation for health, because I think to date that's been somewhat of an ad hoc process. So to document, but also to collaborate with communities and CSOs in looking at what country-specific implementation means in terms of social participation. And I think here is where the whole topic gets quite complicated, because what civil participation looks like is so context dependent and so country dependent, and what happens in Australia is very different from what happens in India, is very different from what happens in Argentina, and so on. But we've decided to start at a very local level and figure out what works in a local context in a small number of countries. And then thirdly, to draw lessons from that country-specific implementation to advance the broader agenda. So think of it as sort of a pilot project for what happens when we are able to provide resources to civil society organizations at the local and country level to work on social participation. The partners so far enrolled, and we've chosen 3 countries to start. So in Vietnam, we're working with SCDI, the Center for Supporting Community Development Initiatives, and we choose a local community organization, but also an academic partner in each of these countries, so that we can do implementation and evaluation at the same time. So we have the Hanoi Medical University, we have Kenya, the Health NGOs Network, or HENET, which is actually a very developed network already, and I'm super pleased to have Rosemary here, because Rosemary has been involved in this for a very long time. And then Argentina, Fundación Huésped, and also the University of Buenos Aires. So 3 very different countries, 3 very different contexts. Rosemary might be able to say about what's happening in Kenya, in Argentina, for example. There's going to be work with transgender communities. In Vietnam, it's completely different. So really local, but very excited by the potential of this partnership to generate research which will catalyze the broader global movement for universal health coverage. So hopefully right at the George is an example of turning the evidence that we're taking into policy, and I would go further than into action. So as I said, start at the global level through a WHA, excuse me, resolution, start at the local level, develop these very local projects on social participation, and find where they meet. So I'm going to end my presentation by coming back to the triangle that moves the mountain, except now that I just want to highlight that it's not just the technical sector and the political sector and the people sector all working on their own. It's that they need to talk to each other. And this is why I find forums such as UHC 2030, but also fora and institutions like the George Institute so useful. I'm not an academic, I'm a community activist, and to have the opportunity to participate and to talk to deeply respected academics that we have at the George is tremendously rewarding. And hopefully this collaboration will enable us to take forward a proactive agenda for action. So I'll stop talking there. I'm grateful for your attention, and I will hand over to my sister Rosemary to have a conversation. Thank you very much.
Thank you very much, Justin, for this lecture, really diving into very interesting and important areas of the work that we do. It is really an honor and my pleasure to share the stage with you. I don't know what time it is where you are, but for me, it's still morning. And also to thank you for the work that you do for us as civil society and communities, and the entire UHC 2030 movement as our co-chair on the UHC 2030, and also all the work we did together on the civil society engagement mechanism, plus all the many other things and initiatives you have mentioned here, the social participation work, the sphere work, and the vision that we all have, including participants on this call. So dear participants, it's my honor and pleasure to take us through the conversation following this lecture. And you are welcome to put in any comments or questions that you might have in the chat. I'll just start with a quick reflection because the lecture today by Dr. Justin Koonin, looking at from evidence to policy as the series of this lecture, annual lecture, but also specifically for the topic today, from global to local and back again, and specifically diving into the topic around community engagement and how community engagement can actually help us to get closer to UHC 2030 and to universal health coverage. And those perspectives are really important. So I'm coming to you from Nairobi, Kenya. This is where I live. And so being in a low and middle income country, I think has a lot of lessons for us as communities, as advocates, as scientists, as researchers, academia, and everyone. And I think the COVID-19 pandemic really opened our eyes and opened, I think, for us, the way we do things and the way we see things in the global health space. And I think this lecture is really timely as we look back to what the experience has been, and as we look forward to saying, how can this experience and the evidence that communities, civil society, all of us as stakeholders, researchers, academic institutions, policymakers, how can we look at that as evidence, and how does it then translate into policy to help us as we work towards UHC, as we work towards preparing and preventing even, the next pandemic. So this is really timely. When I think about health systems, when I look at my country here in Kenya, other countries in high impact, high burden countries, and I look at health systems, our health systems cannot be complete without the community health system component. And this is what you're reflecting also, Justin, in your presentation, that the community health component within the health system is very important. Whether we are looking at community health workers, for me, I always say that community health workers have been the guardians of our continent. Really, if you look at the work that community health workers are doing, but also not just community health workers. We have community champions who really champion the cause. We are talking about leaving no one behind. Justin, as you are presenting the global perspective, and you're sharing with us, the UHC, and really leaving no one behind being a critical component of that. we are really talking about reaching the last mile, I believe. We are talking about ensuring that we leave no one behind. And so I'm picking that from the conversation as something really important and something that we need to think about. And also, I think from communities perspective and the entire ecosystem of health systems, of community health systems, there's also like the end users. So these are people who have to, all of us basically, who have to take action to prevent the next outbreak, hand washing, just the behavior, sleeping under a mosquito net, going for that HIV test. It is also about uptaking treatment and so on and so forth. But we also have the general public who is part of the community. Our perspectives around COVID-19 vaccine, for example, what does that mean in terms of the uptake? What does that mean in terms of absorption and so on and so forth? So this is really timely, and I'm excited that we have some questions on the chat. And it has really given us food for thought. Keep the comments coming. And I think as we transition to that, one of the key areas you have mentioned, and it's tied to the chat, the comment I'm seeing on chat, is about the political commitments. And you've really helped us to reflect on the high-level meeting for UHC that is coming up. And the biggest question you put forward, and actually it's a challenge for me, as I see it as a challenge, sitting here in Kenya, engaging my government in the lead up to the high-level meeting on UHC. And I think the biggest question is, what does that mean for me at the country level, at a community level here in Kenya? Yes, our heads of state will be in New York in September, making these political commitments. But what does that mean for me? And I think it gives us an accountability framework for us to engage. But I think the question you ask is, when the declarations and the political commitments are made in New York, what does that mean for us at the country level? I want to turn to the first comment here or question. It's very specific to the high-level meeting declaration that says that it came out in 2019. And so what outcome is expected out of the UHC high-level meeting on 2023? You have made reflections on this. Maybe, Justin, you could reflect on that, and I'll also add my input to that. But also there is a colleague here who is saying, how can the frontline public health workers contribute to the discussion that will happen at the high-level meeting? So to bring the evidence into that space. And I think it's a broader conversation on the social participation that you have mentioned. How do we give agency? How do we bring all the voices? So I'll turn to you for your reflections, and I'll also share my experience as someone who's really involved in the high-level meeting for UHC right now.
Thanks so much, Rosemary. So let's turn to the first of those questions, and perhaps then you can respond to the same question, and then we can talk about frontline health workers and the other question that I can see afterwards. Correct, and Nita has obviously done a lot of homework and understands the landscape very well. So the declaration in 2019, in some sense, it was a landmark declaration. As I said, it was the broadest, most far-reaching declaration on health in our history. And that was amazing. And it was also, in some ways, part of the issue with implementing it, because it was so broad that countries were saying, great, okay, what do we do next? And the other reality is that countries are in such different places that it's very difficult to have a declaration or a document which covers all country cases and eventualities. This is the first high-level meeting on UHC, but it's not the first health-related high-level meeting. And as far back as 2001, we had a high-level meeting on HIV/AIDS, and following that, we've had high-level meetings on HIV/AIDS 2006, 2011, 2016, 2021. And what we saw through that evolution was a process of increasing focus and increasing specificity and more targets. So one thing, and this is a personal reflection rather than a reflection of representing a movement, but I would like to see us becoming more targeted in terms of what exactly do we want countries to do. So moving from a broader statement of intent to a statement of implementation. What are we going to do next? And I think that would be incredibly powerful. The other thing that I'd like to see out of 2023. And I'm going to complicate the situation a little bit more. But there's actually not just one high-level meeting happening in New York in September, but 3. There's one on universal health coverage. There's one on pandemic preparedness and response. This was a sort of a fairly new eventuality, but put forward by the government of South Africa. That was accepted by the UN General Assembly. And there's also one on tuberculosis, which happens every few years. And what we're seeing is an increasing proliferation to the point of confusion, I think, where each year there are, so many discussions and often fragmented discussions about health happening in so many different places that governments, and particularly heads of state who have limited bandwidth, say, okay, where do we go? Where do we go to next? What should we focus on? So the other thing that I'd like to see around the high-level meeting in 2023 is a much closer integration between universal health coverage, health security, pandemic preparedness in particular, also the disease-specific issues, of course, HIV, AIDS, tuberculosis, NCDs, and so on. But I think this discussion between sort of people working towards health security and universal health coverage needs to be much more closely integrated at the UN level, with a view perhaps towards 2025, 2027 of having high-level summits on health rather than all these disease-specific issues. This also relates, I can see, to the third point there, that UHC is not disease-specific. It's more of a whole systemic approach, but the declaration talks about specific diseases like AIDS, TB, antimicrobial resistance. And I mean, I think the issue is, and I say this as an HIV activist, right? But when disease-specific, sectors and organizations are working in a space like universal health coverage, it's always about, there can't be universal health coverage without my disease, whether it's HIV or tuberculosis or malaria or so on. And so we sort of see a little bit about everyone trying to grab a bit of the pie. And so there's no way that's why we end up with these declarations that are broad, but also mention, almost a shopping list of specific diseases. And it's not that we don't want individualized approaches to specific diseases. I mean, some of the particular anxiety, for example, in the HIV community, is that we've worked so hard around key and marginalized populations. I was speaking earlier about sexuality and gender diverse people, but other key populations are sex workers, drug users, prisoners, and so on. We can't see all of that really good work around human rights let go in favor of generalized approaches, which just say, well, we're just going to provide healthcare to everyone. It doesn't work that way. There might be equality, but it's not equity. So there's this delicate balance between the broad systemic approaches which are needed and also the specific disease-oriented approaches where it makes sense. And that's a negotiation and a delicate conversation that needs to be had. So I'll stop there. Rosemary, maybe you'd like to respond, and then we can talk about frontline healthcare workers.
Absolutely. So I think really spot on in terms of you have broad health and systemic issues and challenges and approach, but you also need and have the disease specific, whether it's TB, whether it's HIV. And I think there is a place where all those meet, because if you're not ensuring that communities, people in a country are accessing their needs, maybe from for TB services, HIV services, maternal health care services, there's no way you are going to actually make progress to universal health coverage. But also in the same way, if you're not ensuring that the human resources for health are catered for, health financing is included, data protection, health information systems, and all that. So it's not one or the other, it's both. But I think also for me, this is where the global meets with the local, because it also means that a country, people in a country have to really sit and think, what does universal health coverage mean for us as a people in our country? And this is the conversation that actually needs to happen with our leadership, with our governments. So if you are talking about how we are preparing in the lead up to universal health coverage high-level meeting, for me as a Kenyan sitting here, I'm already thinking, what is my government going to say when they get to New York? And am I influencing that message? And it links us back to social participation. Are these voices being heard? are we organized in a way that we can contribute to that discourse, to that narrative of what universal health coverage means for us in Kenya, in India, in Australia, in Pakistan, all over the world? That I think that conversation has to start at the country level, form the country position, but also knowing that it's a global movement, and it's really sits within a global health framework. So thank you for that. And I think also very important to mention that the question around what's happening, how we can input. We are also expecting to see the UHC 2030, the action agenda for the high-level meeting coming up very soon by the end of this month. And that will give us also an entry point for participation, for input, for amplification of those messages. But maybe, Justin, I turn to you to see what reflections you have as far as the public health workers comment is concerned.
Thanks. And I think we have recognized, as the world has, that it's kind of one of the health workers is kind of one of these critical pinch points. And unless we sustain and respect and pay appropriately health workers, we're going to be hamstrung in our efforts to address future health concerns. And of course, this ties in very closely to issues around gender, because 70% of the world's health workforce is female. But in terms of specifically the discussion at the higher level meeting, so there are discussions that happen at the high level meeting, and then there are discussions that happen at a national level along the road to and post the high level meeting. So at the high level meeting, there certainly was input from public health from public health workers into the action agenda consultations. And that window has now passed, because the action agenda, actually, we last night we signed off on it, and it will be released in a couple of weeks. There will, of course, be these multi-stakeholder hearings 8th and 9th of May in New York. Obviously, not everyone gets to speak there. I haven't seen a speaker list. I don't think it's been finalized, but I would be shocked if there was not one or more public health workers representing that voice in New York. So those are the windows at the formal high-level meeting itself. But then, of course, there's what happens back home. And to your point, Rosemary, I think part of the critical value of these meetings and the declarations that come out of them, it's not that it's legally binding, it's that back home, citizens and people living in a country can say to their governments, this is what you signed up to, how are you going to act on it? And so the next wave is for health workers to make the case in their own countries. And in that, there's enormous need and enormous capacity. And so that's where I hope the conversation will go.
Yeah, absolutely. Very much looking forward to the pre-high-level meeting, during high-level meeting, and post-high-level meeting. And thank you for reflecting on the question around the frontline workers. Really, like I said, they really are the guardians of our continent, of our countries, wherever we are really doing amazing work. But the challenge you highlighted, Justin, that we are not adequately remunerating the healthcare workers. And so we are struggling. Right now, in most African countries, we are seeing a migration of healthcare workers actually moving to the UK, moving to the US. So there's that migration that we're experiencing. And it's not just in Kenya, it's quite a number of countries, low and middle income countries. But also we are seeing the ratio, whether it's the doctor-patient ratio, we struggle with that a lot, especially in low and middle income countries. So there is a question around how do we ensure that healthcare workers, especially community health workers right now, because in our experience, are not remunerated. They are not put in the government wage or salary scale and all that. So in Kenya, for example, there is a bill in Parliament that has been sponsored there by one of the members of Parliament that is looking at structuring community health workers into a structured salary plan and all. That means that it's going to be predictable for them, but they are going to be adequately remunerated. And I think this ties back to the social participation question to say, Is there community, civil society voice actually speaking in support and contributing to these decisions and legal processes to say, if we paid our healthcare workers better, if we had a law that protects their remuneration, that would help. So I think it's that participation you are referring to within the social participation agenda. That takes me to another question here that's also is really focusing on community health, on health workers, but has an angle on misinformation and disinformation. One of the things we saw during COVID-19 was the whole issue of infodemic. There was all these outbursts of information, and it was really difficult to figure out what was valid, what was not valid, what was not true, what was not true, especially even because we saw scientists, you know, having different opinions as we were all struggling and trying to understand the science of the virus. And so the question is really about how should health workers approach this challenge, especially with regards to promotive and preventive health. So with all this information, disinformation traveling faster. I know you have thoughts around that in terms of the misinformation. And I want to say, like, from my experience and perspective, there's a lot of trust elements within that, within how public perceives information, how public interprets information. So it's really also a bigger question around leadership, around how we as public perceive the public system, the public health systems, and so on. So anyway, I think touch on that, Justin, and then we can look at to see if we have additional comments.
Sure. I think it's a really interesting question, a really interesting topic, because in some sense we're dealing with, I mean, there's always been misinformation, but what's happened in the last few years at the speed at which misinformation and information can travel, so it's a double-edged sword, it's good and it's bad, can travel, is much, much, much faster. And so the misinformation wave that we saw during COVID perhaps spread a little faster, or maybe much faster than it would have in previous eras. It is, of course, really challenging. I would say that it happens all around the world. You know, I'm part of another process, which I haven't talked about today, but another interesting process called the Universal Health and Preparedness Review. It's basically a new WHO-led mechanism, but actually member state-led mechanism with WHO support around peer assessment of health system capacity for emergency preparedness. And so I was in Thailand talking to civil society organizations in Thailand in April. And they were saying exactly the same thing. You know, how do we deal with this misinformation? So I think it happens everywhere. And I guess, I mean, it's very difficult, but I would come back to my point about communities. We need to ask ourselves who is, and your word was trust, Rosemary, but where is the locus of trust in the community? The power of community organizations is that is where communities will go after developing that trust over many years for information. If my community in Australia wants to know what's happening with a health issue, they're going to ask ACON. If I was in the slums in Klong Toi in Bangkok, they're going to ask Klong Toi Dijang or one of the youth organizations. So I want to emphasize, or maybe emphasize again, the power of community in being a locus of trust. And I think that's a good way to cut through disinformation.
Yeah, absolutely. It takes us back to the entire ecosystem, health systems, and situating community health systems within that, and recognizing that within community health systems, you have community health organizations that for many populations are actually the first point for, I think, to respond to anything. They are trusted, they have worked with communities, but I think one of the things you mentioned when you were talking about Sphere, the new program that is in 3 countries, is that I think it's really important to strengthen local organizations. We talked about some organizations in Vietnam, in Kenya, and is it Argentina? Sorry, I forget the 3rd country.
Yep.
Yeah, and so I think what I really like about what you said and the vision there is for Sphere is that it's really about local organizations. It's supporting local organizing. It's supporting local organizations where people can feel free to access, to talk to engage. And I think when you say it's a locus of trust, it's really manifests in how people actually choose to go to the local organizations for the information. And I think it's also a great point for community health workers to collaborate with local organizations, especially when there is doubt and when there is a crisis within the health system, like we have seen. I want to actually go to another question that has been asked around gender. It connects to the high-level meeting. I know we talked about the high-level meeting, and we talked about the action agenda coming out very soon. I don't know what we can talk about the action agenda now before it's launched, but, and I'm not sure what is in there about gender, because the question is whether it will focus on reproductive health access or health across life course of all genders. So this is the question. And as you reflect on that, Justin, I did want to emphasize a point that you had put about local organizing and social participation at the country level, that no matter what the action agenda will have as the key asks, it will be very important that we organize at the country level, at the local level, so that if, for example, gender is reflected in a certain way, yes, we need to amplify that within the action agenda, but we really need to also have a conversation at the country level. What is our view and perspective around gender as far as UHC is concerned? What are the gaps in our country? What would we like to see? What does it mean for us? So that's a conversation that really needs to happen with us and our leadership at the country level, while also amplifying the key messaging at the global level. But I don't know what your take is, Justin, as far as gender and the action agenda is concerned.
Thanks very much. And thank you for that question, which is, again, a really good one. I won't do a full reveal of the action agenda because that's going to be launched on, I think it's March the 27th. Stay tuned. Except to say that the action agenda sort of area on gender equality will be fairly broad-based. And so it will be about guaranteeing gender equality across health systems and decision-making at all levels. It'll be about closing the gender pay gap. And as we spoke about previously, valuing and appropriately remunerating both unpaid and underpaid health and care workers, including community health workers. It'll be about eliminating gender inequalities and discrimination in both the design and delivery of health services, and also about data, about how we collect the best available knowledge and information on gender priorities and challenges so that we improve policy design. So it'll certainly be broad. Having said that, actually, sexual and reproductive health and rights is a really interesting political flashpoint, and it's unfortunate it's a flashpoint, but those of us who were around for the 2019 meeting will recall that there was a coalition of about 18 countries who came out on the day of the high-level meeting and essentially dissociated themselves from the text of the political declaration. It included somewhat, well, I guess not surprisingly, given who the government was at the time, but included the United States of America and many other countries, and basically said that, you know, sexual and reproductive health rights don't exist, more or less. So we can expect that SRHR will be a political flashpoint. I'm sure we'll be heavily involved in discussions during the high-level meeting, but the agenda for gender equality will be much broader than SRHR.
Yeah, that's very helpful. I think it's definitely is usually a hot point when we talk about SRHR. I know in our region, the African Union member states are very hesitant around, for example, comprehensive sexuality education, but communities and civil society on the other end is one of the things that we really try to push for, to see commitments in there. And that's why I always see the high-level meeting declaration is always a negotiation. You have people promoting certain language, and you have people completely opposed to certain language. And so one of the things I have seen communities and civil society do is to actually develop what we call non-negotiables or a language that cannot be compromised. So basically you outline a number of key asks to say that these are non-negotiables. If we are going to make progress to universal health coverage, it will be important that we have A, B, C, D, and I know SRHR is one of the areas where we always try to make sure that it enters into the non-negotiables document. So as communities, this is the document we use to try and push for, to persuade our leaders as they develop the final declaration to actually reflect on this. So, and I think maybe the other thing, I do not think there are comments here, but I wanted to pick another item you had mentioned, Justin, when you talked about universal health coverage, like when you were defining and you were saying what it is, and you presented the cubic and talked about the 3 dimensions in terms of who is covered, in terms of what services are covered, and at what cost, is that service being provided. And I see that also as a really good link, across, the global, local social participation kind of theme that you kept in your presentation, where you have this global definition, around UHC. It is the accepted and agreed upon definition. But when it comes to conversations around who is covered, when we come to conversations around which services are covered, it really is a local conversation. So for example, in most of our ministries, that conversation or the decision to that is reflected within the health benefits package. The health benefits package that outlines which services are covered through the UHC program. And then at what cost is also a decision that is made and how it is paid, whether it's through the national health insurance, the national social security, and so on and so forth. And it links to social participation because the idea of who decides which services are covered, who decides which populations are covered, who decides which populations are being left behind is really a local conversation and really a good example of social participation. I don't know what experience you might have or reflection you might have around this aspiration we have on UHC, but how decisions to that actually are local and how communities, need to get engaged in those decisions through social participation.
Yeah, I agree with you. It's a completely local, well, it can be a completely local decision. And then the other dimension which overlays the complexity is that it's both a technical discussion and it's a political discussion. And sometimes these intersect in helpful ways and sometimes these intersect in unhelpful ways. It's a technical conversation in the sense that no country can provide services or all services to all people because they don't have resources to do so. And so there need to be technical conversations around how do we prioritize. It's a political conversation because in many countries there are marginalized opportunities who aren't provide services, and I'll be blunt here, not because the government can't provide services to them, but because they don't want to, whether that's LGBT people, whether that's drug users, whether that's sex workers. And in that context, I think it's particularly important that local communities raise their voices. In the HIV movement, the progress was made because it was affected communities who stood up and roared. And I think that notion of community ownership really needs to spread. It is in some contexts, but in many it is not, really needs to spread across the global health world so that the progress will be made precisely by the local communities calling for their right to health.
Yeah, absolutely. And you mentioned something really interesting that we have to think about, because when we talk about making progress to universal health coverage, I think we have to bear in mind that in some countries, we do have like criminalized populations. We have populations that are not able to access health services in an adequate manner because of how they are perceived and how they are categorized at the country level. You talked about LGBTQ communities. In some of our countries, we also have sex workers who in some instances actually experience violence, which also hinders their access to services. And my question has always been, as long as we have communities who are marginalized, communities who are criminalized, how exactly are we going to make progress to UHC? Because UHC is universal, and UHC means everyone. And I've seen with ACON, when you presented the local experience with ACON, providing services, reaching out to populations that are being left behind, ensuring that populations that are not part of the maybe government system are actually reached. And the fact that those populations also feel free to approach organizations like ACON because they feel safe, they feel it's a safe space. So I think it's a mix of many things. You have, on one hand, populations being left behind, but then you also have organizations that really are like a safe space for these communities. But I always wonder, how is there a place where this meets, criminalization, marginalization, leaving people behind, and their aspiration to actually ensure that we have universal health coverage, which is universal. I don't know what your reflection is, but it's an area where I think we need to do better as a global community.
Yeah, I agree with you. And I mean, I would say that UHC is not a defined endpoint. It's really a process, and there's no country in the world which is effectively providing all the services it needs to all people, and every country, including my own, is on that journey. So I think we should see and celebrate progress where it happens. And if a country doesn't have a national insurance scheme and institutes a national insurance scheme, and at the same time that country is still criminalizing key populations, I mean, that's progress. I wouldn't call it UHC, but it's a step in the right direction. Someone wise once told me that you cannot turn an avocado into a zebra, even if it would be to your advantage to do so. And so I think we also need to be realistic that these changes take time. And of course, if your country is criminalizing LGBT people, of putting them in jail, if your country is shooting drug users and so on, you are not providing UHC. I don't care what you call your national insurance scheme, right? But we have to see it as a sort of a process that occurs in stages. And in many countries of the world that is happening, and it's important to play the long game.
Absolutely. Thank you so much, Justin. One thing that will stay with me, it has stayed with me, but you've reminded me, is where someone said that, is it really possible to achieve universal health coverage? Is it really possible? Or is it an issue of making progress to universal health coverage? When do we get to universal health coverage? Is it possible? I'll leave that to you as you come for your final closing remarks, but I did want to reflect that from where I sit, it has really been an amazing conversation. The presentation itself, covering the global components on universal health coverage, coming to local with the experience from Australia, the work that ACON is doing as an example of how local organizations can take leadership, and going to social participation, really taking us through how local communities, how communities can actually engage in policy conversations, how they can engage in making a difference at the country level, in having their voice heard, and taking us through various nuggets of this universal health coverage conversation, the opportunities we have with the UHC high-level meeting coming up in September, not just at a global level, but what we can do to participate at the local level, national level, the entry points, the questions around gender, the questions around healthcare workers, communities, and helping us to reflect on that. And we await to see the action agenda and how we can engage and participate on that. And I think for me also, your reflection on everything goes back to communities. Everything goes back to community in terms of it being a locus of trust. And it ties into what Tedros, WHO director, says a lot of times, that there is no global health struggle or fight that will truly be successful without communities. And this is what it has been about. So I hand it to you, Justin, for your final reflections.
Thanks. Well, I don't think I could do a better final reflection than you just did. I don't think we ever get to universal health coverage. I think there's always going to be work to do, but I certainly think the world can be in a much better place than it is. And what we've seen over the last 3 or so years from COVID has really highlighted the ways that inequities operated before, but now were magnified by the pandemic. So it's been very difficult in many ways, but also a huge opportunity for us to do things differently. So to all of you who have joined us today, thank you. Please don't go away and say that was a nice lecture or that was a boring lecture. Please go away and do something because we need an army. Thank you very much to Vivek and to the George for having Rosemary and I today. It's been terrific to join you. And I think we now hand back to the George for some final comments.
Okay. Thank you so much, Dr. Justin Koonin and Ms. Rosemary Mabru, for the most engaging and insightful talk today. Ms. Rosemary, thank you so much for the beautifully summarized points shared by Dr. Justin. And I'm sure our most curious audience will be interested in learning more about it and will continue exploring these perspectives in their respective works. We again express our gratitude to you both for taking out the time today for the lecture. And thank you to our audience as well for patiently listening to the lecture and for actively partaking. We wish you a pleasant day ahead. Thank you so much.
Thank you. Bye-bye.